Welcome back to All About Rx. Today, we are breaking down the chemistry, secretion, and clinical uses of proteinous hormones like glucagon, oxytocin, antidiuretic hormone or ADH, and insulin. We've got a lot of fascinating molecular structures to unpack today, and we're going to see exactly how the shape of these hormones directly dictates how they behave in the human body.
Here's our agenda for today's explainer. We'll kick things off with a quick overview of proteinous hormones, then dive right into glucagon, followed by oxytocin, ADH, and insulin. Finally, we'll wrap the whole thing up with a massive clinical takeaway we call the Golden Rule.
Okay, Section 1, Proteinous Hormones Overview. Let's cover the basics.
So by definition, protein-based hormones are made up of amino acids. And because of this structural makeup, they're highly polar in nature. Now, what does that actually mean for us? Well, it means they dissolve super easily in polar solvents like water, and more importantly, our blood plasma. But navigating the bloodstream isn't always a walk in the park. Because they are so polar, they typically need specialized carrier proteins to sort of shuttle them efficiently through the blood right to their target organs.
Moving right along to Section 2, glucagon, the glucose mobilizer, secreted by the alpha cells.
Now, compared to what we're going to look at later, glucagon's structure is incredibly straightforward. It's a 29 amino acid peptide hormone produced by the alpha cells of the pancreas. We're looking at a single, straight polypeptide chain here. Notice the N-terminal end features histidine, and the C-terminal end finishes with threonine. But the real defining characteristic, there's a complete and total lack of disulfide bridges, 0. It's just a linear sequence with no loops or crosslinks. Oh, and unlike insulin, it doesn't even need zinc or any other metals for storage or crystallization. Functionally, glucagon's main job is to regulate blood glucose by mobilizing metabolic substrates from storage. Its secretion is tightly regulated by blood sugar, so a rise in blood glucose naturally inhibits its release. Clinically, this makes it an absolute lifesaver. It is literally the go-to treatment to reverse severe insulin-induced hypoglycemia. If a patient is completely unconscious and can't take glucose orally, a 1 milligram injection of glucagon, which equals 1 international unit, is a vital first aid measure. You can give it intramuscularly, intravenously, or subcutaneously.
Let's jump into Section 3, oxytocin, the bonding peptide, traveling from the hypothalamus down to the pituitary. So while glucagon was 29 amino acids long, oxytocin is much smaller. It's a tiny 9 amino acid neuropeptide that's synthesized in the hypothalamus and released from the posterior pituitary. But hey, do not let its size fool you. Take a close look at the linkage. There is a very specific interchain disulfide bond between the cysteine at position 1 and the cysteine at position 6. This single bond folds the chain into a really distinctive 6-membered ring with a little 3 amino acid tail.
In the body, oxytocin is famously released during social bonding and childbirth. The signals are relayed in milliseconds via spinal reflexes straight to the brain, causing the posterior pituitary to dump oxytocin directly into the bloodstream. Clinically, its main action is triggering uterine contractions and milk ejection. But because it's a neuropeptide, it would be totally destroyed in the gastrointestinal tract, so we have to use an IV infusion or a nasal spray. We actually even use it in veterinary medicine to help facilitate birth and boost milk production in animals.
All right, Section 4, ADH, or Vasopressin. This one is all about managing water balance.
Now, while oxytocin focuses on labor, ADH has a totally different target, the kidney collecting ducts. Its main action is antidiuresis, meaning it drastically increases water reabsorption by opening up aquaporin channels. Because of this powerful water-retaining effect, ADH is the absolute primary replacement therapy to manage diabetes insipidus. It helps control the frequent urination and intense thirst that patients with that condition deal with.
And honestly, this right here illustrates the absolute magic of biochemistry. If we compare them side by side, both oxytocin and ADH are exactly 9 amino acids long, they are both synthesized in the hypothalamus, both have that exact same cis-1-cis-6 intrachain disulfide bond. The only difference between them is at residues 3 and 8. Where oxytocin has isoleucine and leucine, ADH swaps in phenylalanine and arginine. That's it. Just swapping 2 tiny amino acids completely shifts the hormone's job from inducing labor to drastically altering kidney water retention. It is just incredible how precise our biology really is.
Which brings us to Section 5, insulin, the complex anabolic, secreted by the beta cells.
Okay, if glucagon was a simple straight line, insulin is an absolute architectural marvel.
It is a 51 amino acid anabolic hormone composed of two distinct parts, a 21 amino acid A chain and a 30 amino acid B chain. Also, remember how I said glucagon didn't need metals? Well, insulin actually requires zinc for crystallization, which makes perfect sense when you realize that normal pancreatic tissue is naturally very rich in zinc.
The crucial point here is how these chains actually stay together. The A and B chains are locked tightly in place by two interchain disulfide bonds. On top of that, the A chain has its own additional intrachain disulfide bond right between its 6th and 11th positions. This structural integrity is literally everything. If you break these disulfide bonds using alkali or reducing agents, the insulin is instantly inactivated. Game over.
When a patient has an absolute or relative insulin deficiency, it results in diabetes mellitus, causing dangerous hyperglycemia. For folks with type 1 diabetes, their bodies depend entirely on external insulin to manage their condition. Clinically, it's typically supplied in concentrations of 100 units per milliliter and administered via subcutaneous injection. Dosing is highly individualized by the prescribing doctor, usually ranging from 0.2 to 1 unit per kilogram per day, and that goes for both adults and pediatrics.
Finally, Section 6, the Golden Rule. Let's cover some crucial clinical takeaways.
I really want you to think critically about this for a second. We've just established that patients frequently need to supplement glucagon for hypoglycemia, oxytocin for labor, ADH for diabetes insipidus, and insulin for diabetes mellitus. But in every single case today, we talked about IVs, injections, or nasal sprays. So why can't we just swallow these hormones as a daily pill?
Well, it's because they are completely destroyed in the gastrointestinal tract. Because all these protein hormones are destroyed in the gastrointestinal tract, none of them can be given orally. Our proteolytic enzymes in our stomachs digest them exactly like they would a piece of dietary protein. They rip apart those delicate amino acid chains and disulfide bonds, totally inactivating the hormone before it can ever reach the bloodstream.
So before you go, consider this. If scientists can eventually engineer a way to shield these fragile disulfide bonds from our stomach acid, how drastically would an oral insulin pill change the landscape of global diabetes management? Thank you for tuning into this lecture. If you found this breakdown helpful, please make sure to like, subscribe, and drop a comment below with any questions or topics you want covered next. See you in the next explainer.